We'll talk about, we are talking a little bit about iron supplementation in CKD, and then about ferric carboxymaltose. It's one of the new kids on the block. We have a lot of iron preparations nowadays. So we'll be talking a little bit about iron, what is iron, how is iron, why we need iron, and how we can control iron deficiency. So a little bit about iron. Iron is widely available, it's abundantly available all over the world, and therefore there is no shortage of iron as far as organisms are concerned. But unfortunately, it's a limiting factor for growth in organisms. That is because most of the iron present on Earth is in the insoluble oxide forms. And free iron from this is difficult to extract, and organisms need free iron for their metabolic processes. So all organisms have got mechanisms to reduce oxides and convert them into more absorbable, more water-soluble compounds, and which can be utilized much better in the body. Iron is mostly in hemoglobin and myoglobin in the human body. That's the most important reason for us to have iron in our systems. So a little bit about iron absorption from the intestine. So you see, iron in the intestine is actually absorbed in two forms. One is heme iron. Heme iron is exclusively for where is the pointer? Yeah. So heme iron is exclusively for non-vegetarians. It's not there in vegetarian food. And heme iron is absorbed by a different pathway. There's a heme transporter, and this enters the cell through that and is oxidized by heme oxygenase and then converted into ferrous iron and taken up into the blood. So there's a very simple pathway. It is not subject to any regulation, and whatever heme is there can be absorbed. So it's a good way, but unfortunately, heme is not available in large quantities. Even those who eat meat will not have sufficient and cannot be taken up by intracellularly. So it is converted to ferrous form by this molecule known as a duodenal cytochrome B, and that will convert ferric form to ferrous form, and the ferrous form is then taken up by this transporter, which is known as the divalent metal ion transporter 1, DMT1. So inside the cell, you must remember that iron is a compound which is very unique in the sense that it can be both oxidized and reduced. So that's why it can participate in a wide variety of reactions in the human body. Now, the downside of that is that every compound in the cell can attach to it and cause it release of electrons or transfer electrons, and therefore it can cause a lot of oxygen-free radical generation. That's one of the problems with iron. It's a highly toxic molecule when it's left alone, and therefore in the cell it has to be confined to a space, and that is called ferritin. So this ferritin is a molecule which consists of multiple iron molecules attached to a protein which is known as apoferritin. And that is the storage form of iron. It is present in the cell. And if the iron, nothing else happens to the iron, once the intestinal cell is shed, this iron is lost back into the stools. But when the body needs iron, it can be extracted from this ferritin apoferritin complex. And then this ferrous iron, which is released, is then taken up by this transport known as ferroportin 1. And this ferroportin 1 will transport the ferrous iron into the blood, where it is acted upon by this molecule known as hephaestin and converted back to the ferric form, in which form it is attached to transferrin. And transferrin will then take it to multiple places. You can take it to the liver for subsequent metabolism and storage, or you can take it to the marrow where it can be used for erythrocyte synthesis. But this transferrin is the main protein which transfers iron in the blood. And the cells which take up the transferrin have what are called transferrin receptors on their surface, or TRs. And therefore, this transferrin receptor complex is very important for uptake of iron into the cells. So you can see that ferroportin is an extremely important molecule here for transit of iron out of the cell. DMT is a very important molecule here for transit of iron into the cell, into the intestinal cell. DMT is present exclusively on intestinal cells. So these two molecules are the most important things which we have to remember, even if you forget everything else from this lecture. Now, there comes a new player. It's known as hepcidin. Hepcidin is a molecule inside the liver and has got an extremely important negative feedback expression upon iron. So hepcidin will do two things. One, it inhibits this DMT1 and prevents the uptake of iron. But that is not a major mechanism of action of hepcidin. The main thing it does is block ferroportin. Now you must understand that ferroportin, which we have already seen in the intestinal cell here, is the only iron export protein present in all the cells in the body. So whichever cells contain storage iron, they can only release iron through the ferroportin molecule. So hepcidin inhibits ferroportin everywhere, whether it's on the intestinal cell, whether it's on the macrophage, which takes up these senescent RBCs and breaks down the heme into iron and stores it there, or whether on the liver cells, which also store iron. So all of these cells will release iron only through ferroportin, and hepcidin will inhibit all these ferroportins everywhere. So once hepcidin is released, iron cannot be released from the cells, and iron cannot be taken up by the erythrocytes or whichever cells that require iron, and therefore there will be anemia. So hepcidin released by the liver is an acute phase reactant, and therefore it can be released in times of infection, other things, which is the most important reason for chronic anemia in infections and in immunological disorders, collagen vascular disorders, etc. Now, why hepcidin? The other problem now we're talking about CKD. Why oral iron is very poorly effective in CKD? That we know for a long time that giving oral iron patients with CKD is not effective. Now, one of the most important reasons that CKD is an inflammatory disorder and hepcidin is released. But there's also one more important reason: hepcidin is metabolized and inactivated by the kidney. So if the kidney is not working, then hepcidin levels will go up in the body. So hepcidin is already, levels are high when there is CKD, and therefore iron cannot be absorbed because of hepcidin. But there are other reasons why iron is not effective in CKD: because of blood loss and dialysis, other ways of blood loss. You do a lot of phlebotomies, you subject these people to a lot of tests, and therefore a lot of blood is removed from the body for that. Then there is decreased acidity of the gastric mucosa. Most of the patients are on PPIs or on H2 antagonists, and also on multiple drugs that react with oral iron, and therefore affect the absorption of oral iron. And many of these drugs which are used that supply oral iron, they have severe GI side effects. And already these patients with CKD have GI side effects, and therefore they cannot tolerate these drugs, even less tolerable than those patients without CKD. So for these multiple reasons, oral iron is not effective in CKD. But one of the most important reasons is hepcidin, as I already said. Now, despite that, what oral iron formulations are still used in CKD? We should know these oral formulations. Ferrous sulfate is the most common iron to be used and still the most cost effective, but almost 50% of people have side effects in clinical studies. In patients without CKD, in patients with CKD, it's going to be even more. Ferrous fumarate has also been used, but side effects profile, when you looked at the studies, are even worse than sulfate. So in ferrous sulfate was around 45% or so, but ferrous fumarate was about 48 to 49%. That GI side effects. That is, those are not in patients with CKD, those are patients with iron deficiency anemia with various conditions, and therefore you can imagine that patients with CKD will have much worse effects. The third thing is ferric citrate, which is now being released and used as a phosphate binder, but it has got a very high iron content. So iron content of ferric citrates is almost 210 milligram per tablet. So which compared to say ferrous sulfate is got only 60 milligram per tablet. So you can see that the amount of iron in ferric citrate is very high. But remember, this iron is in ferric form, whereas all the others are ferrous form. And as I told you earlier, ferric form is not very well absorbed by the, so but the body will have to convert that to ferrous in order to absorb. So this actually, ferric citrate has been approved by FDA for treating iron deficiency anemia, but for some reason or the other. And then ferrous gluconate, it has less adverse effects, but it's not as effective as ferrous sulfate. There's another compound is ferric maltol, which has been used in patients with inflammatory bowel disease. But there has been no experience in CKD. Side effects are believed to be better with ferric maltol. But I don't, as far as I'm aware, it's not available in India. Then, of course, we are all using liposomal iron. It's an iron molecule, but it's iron pyrophosphate, or also known as sucrosomal iron, which is stored in a phospholipid bilayer. So it behaves like a liposome, and therefore it's absorbed much better. So the side effects in CKD appear to be less, but there have been no actual clinical trials which have shown that very well. But hemoglobin does rise, and all of us use a lot of oral iron, liposomal oral iron. So then coming to intravenous formulations of iron. So one of the first formulation was iron dextran. I remember that most of us who are on the wrong side of 40 will remember this molecule quite well. It was there when we were all doing our MBBS days and all that. So iron dextran was a large molecule. Two compounds are available. What's known as Imferon and Jectofer. And this was the original iron formulation, large molecular compound, could be given as, so you calculate the total dose infusion. Based on the hemoglobin, you can calculate what is the iron deficiency and then give 1,000 or 1,400 or 1,500 milligrams of iron in one condensed infusion. Unfortunately, the problem with this iron dextran is anaphylaxis. It was, most of the anaphylaxis was fatal, and anaphylaxis was not uncommon with these molecules. So That is why this went into disrepute. So it was used only in extreme cases. The patient had to be admitted to the hospital, probably monitored carefully while the iron was being given. But then came the low molecular weight iron dextran, which was there in the 1990s. It was derived from the above. It could not be given as a total dose infusion because being a low molecular weight compound, there was significant risk of release of free iron. And as I told you, free iron is a very dangerous and toxic molecule. Therefore, you cannot give as total dose infusion, but you can give as a small boluses. But the reactions were much less with low molecular weight iron dextran compared to high molecular weight iron dextran. But it was still present. Serious anaphylaxis was still an issue. So that caused the research into iron molecules, IV, and then iron sucrose came out. This is one of the most commonly used iron agents, but you cannot use more than 300 milligram. The risk of fatal anaphylaxis is extremely low, but reactions can occur, though not serious. And then sodium ferric gluconate has also been known to be a compound. I don't know if it's available in India, but it can be used up to a dose of 250 milligram infusion. Ferumoxytol is widely used in the United States. It's a very safe iron molecule, and the dose is 510 milligram per infusion, which is given. And reaction rates is very little with ferumoxytol. And lastly, we have a compound we are going to talk about today, ferric carboxymaltose. So these are the various iron preparations. So why do you want to give IV iron instead of oral iron? The main three reasons are that it is a fast repletion of iron stores, it is safe if formulations of dextran are avoided, and is effective even when intestinal absorption is impaired. And like I told you, oral iron has got a lot of side effects which lead to the inability of the patient to take the oral iron compound in the first place. So what about ferric carboxymaltose? Little bit about ferric carboxymaltose. That's an intravenous iron preparation. It's approved for the treatment of iron deficiency in adult patients. Especially the FDA's approval is for those who have intolerance to oral iron, or who have unsatisfactory response to oral iron, or who have non-dialysis dependent CKD. So this is not approved for dialysis dependent CKD so far. It's a colloidal solution of nanoparticles that consists of a polynuclear iron 3 oxide. That is, iron 3 means it is a ferric compound stabilized by carboxymaltose. So it's a high dose, well-established, effective and safe option for correcting iron deficiency. And the PKPD properties is that it is actually a ferric hydroxide core stabilized by a carbohydrate shell. And because it is a very macromolecular design, it will allow for a controlled delivery of iron and will deliver the iron to the cells of the reticuloendothelial system, especially in the bone marrow. And subsequent delivery to iron-binding proteins, ferritin and transferrin, and minimal risk of release of iron, toxic ions into the serum. Free iron is not released into the serum because of that. And the IV administration results in correction of hemoglobin levels and replenishment of iron stores. So as you show by transient elevations of total iron serum levels, and ferritin levels and transferrin saturations all go up because of the administration of ferric carboxymaltose. So it is a very useful molecule and very, very little toxicity, especially due to free iron. So the concentration of iron in the serum is increased rapidly in a dose-dependent manner. It is rapidly cleared from circulation and distributed primarily to the bone marrow. About 80% goes to the bone marrow. And repeated weekly administration does not result in accumulation of transfer iron in patients with iron deficiency anemia. So if you give without iron deficiency, problems can occur and should not be probably used. So what are the clinical evidences for FCM? So the initial studies were done, actually they have done patients with heart failure, even in those without iron deficiency. So this was confirmed HF, which is a study in heart failure patients. So the 304 patients, symptomatic heart failure patients, actually they're HFrEF patients, those with low ejection fraction. And the primary endpoint was a change in 6-minute walk test. So they saw whether these patients could actually improve their walk test distance. There are a lot of secondary endpoints we've seen this, and you can see that 152 given FCM, 162 given placebo, just saline. And you can see that at week 24, there was a significant increase in 6-minute walk test when this was given, FCM was given. And not only that, if you look at secondary outcomes, if you look at the global assessment scale, it was better with FCM. If you look at the NYHA functional class, that was also better with this. If you look at the fatigue score, that was also better with there's much less fatigue with the red line, and that's the FCM curve. And the KCCQ, which is a Kansas City cardiomyopathy for the questionnaire, and this actually shows you the improvement in cardiovascular symptoms after a particular treatment. And again, that also shows improvement. So definitely, not only quality of life indices and cardiac failure, everything improves when you give FCM in these patients, iron deficiency anemia. But there's another study known as EFFECT-HF, and this showed that patients with systolic heart failure that is left, he'll be with mild or moderate symptoms. And these patients were not actually iron deficient at all. So those, whether they were iron deficient or not, they were taken up for the study. But the primary endpoint was a change in the peak VO2. So the VO2 is the oxygen consumption, which is at peak exercise. And that is what is taken as the endpoint in the study. So whether the oxygen consumption improved at peak endpoint, that was the conclusion of this study, the primary endpoint of this study. So there was 86 care and standard of care. So the control group was a placebo control, but this was a blinded endpoint study. So the endpoints are evaluated by a completely blinded group of evaluators. And you can see that it has got a beneficial effect on peak VO2 compared with standard of care. So definitely it's effective. So not only the FCM is effective in iron deficiency patients, but it's also effective to improve cardiac failure in those patients without iron deficiency. So that is the conclusion of this effect HF trial. But there are trials in CKD which are more interested in. So this is a fine CKD trial, 626 patients with non-dialysis dependent CKD, anemia, and iron deficiency. So these patients were not receiving ESAs, and they were randomized to receive either a high ferritin FCM, that is the target ferritin in this group was 400 to 600. The target ferritin in the lower ferritin group was 100 to 200, and oral iron therapy. So these are three groups. This is an open label, but multi-center prospective randomized 3-arm study. So the primary endpoint was time to initiation of other anemia, whether you are given ESA, other iron therapy, or blood transfusion, or a hemoglobin trigger of 2 consecutive weeks. So either the hemoglobin not improving over 2 consecutive weeks. So these were the two primary endpoints which were monitored in this trial. And you can see that the trial endpoints were much, much better in the high ferritin group compared to either the low ferritin group or the oral iron. And similarly, the mean hemoglobin also rose in the high ferritin group compared to the other groups. But here you can see that even the low ferritin group had an increase in hemoglobin compared to the placebo group or standard of care. And not only, if you look at the values for these are the various other trials which have compared FCM with either oral iron, placebo. So this is a comparison between FCM and either oral iron or placebo. And you can see the black bar outdoes the other bars in most of the studies. In some of the studies, it's just barely equal, but most of the studies it does outdo. And if you compare the iron sucrose also, it looks much better than the comparator. And again, this is the normal hemoglobin level, which is present in these patients, and whether these people achieved a normal hemoglobin level or not. And that is also much better for FCM, whether you compare with oral therapy or whether it's compared to iron sucrose. So the hemoglobin increase and percentage of anemia correction are all better with FCM compared with either oral iron or iron sucrose preparations. What about ferritin and TSAT? So that was also much better with FCM compared with placebo, FCM compared with iron sucrose. And you can see that this is for ferritin and this is TSAT. And again, the same values which are shown in both of these. So you can see that it's much better. So FCM is not only superior to placebo, but it's also superior to iron sucrose when you are giving to non-dialysis CKD patients. And these are the values of all the trials which have been done in non-dialysis CKD patients, FCM iron. And you can see that this was, most of the trials have shown a mean hemoglobin increase of 14 grams. This is about 101 gram per liter. So this is the baseline value, 101, which we'll call 10.1. And the increase was about 14.9, etc. in all the trials. So definitely FCM causes increase in hemoglobin levels in all the clinical trials. And even when compared to iron sucrose or oral iron, the conversion is much better. What about tolerability? So if you see that the reactions due to infusion, headache, then injection site reactions, etc., they are slightly more than FCM. But you look at the other GI side effects, nausea, constipation, diarrhea, abdominal pain, vomiting, that's all much more the oral preparations. In fact, constipation, there is no comparison, 11% with ferrous sulfate, whereas almost nil with FCM. So definitely, if you look at the side effect profile, it's much better for FCM compared to oral iron. So a little bit about FCM and serum phosphorus. So it's actually an interesting phenomenon. FCM was shown to reduce phosphorus in pregnant women initially. That was a problem, but subsequent, the initial study CKD showed that less than 2% of CKD patients had a hypophosphatemia. But this was not measured properly in those trials. I don't think most of the trials included the phosphorus measurement as part of the evaluation. But subsequent careful evaluation showed that phosphorus reduction occurred in more than 50% of studies. In a study that carefully evaluated 35 out of 47 patients developed hypophosphatemia in those who were given IV FCM. So how does this occur is due to the renal phosphate wasting, and that is because FCM reduces FGF23 levels. So maybe this may be an important mechanism subsequently for the nephrologist to treat FGF23, but right now it is still mentioned as a side effect. So reduction of serum phosphorus FCM, an interesting, maybe helpful side effect in patients with CKD. So what are the take-home points from this presentation? That iron deficiency anemia is the most common form of nutritional anemia worldwide. Oral iron is considered the first line therapy for treating iron deficiency due to its low cost, good safety profile, and ease of administration. But the absorption of oral iron is affected by several factors, and incidence of GI side effects can lead to a lack of adherence as well as poor efficacy. And therefore, you need IV iron, of which ferric carboxymaltose is a non-dextran intravenous iron form. It has been approved for use in patients with iron deficiency and in patients, especially in patients with non-dialysis dependent chronic kidney disease. And we have demonstrated clearly the safety and efficacy of FCM in various clinical trials, and is non-inferior to other iron, in fact, maybe even superior to iron sucrose, and produces much fewer anaphylactic reactions. So that is my presentation. So I'm open to questions and doubts, clarifications, etc. Thank you.